Hi, I'm Francisco Javier Esteva. I'm the Chief of Hematology and Medical Oncology at Lenox Hill Hospital in New York City. Today, I'll be speaking with Dr. David Langer, who's the Chairman of Neurosurgery at Lenox Hill Hospital. Dr. Langer is a very well-established, very famous and respected neurosurgeon, and he's done a lot of research in vascular surgery and other areas. He's also highly regarded not only as a surgeon, but also as an amazing communicator. And today we'll be talking about his interest in neurosurgery, his leadership style, and much more. So thank you, Dr. Langer, for doing this podcast with us.
My pleasure.
So can you tell us a little bit how you started your career, as what made you interested in neurosurgery to start with?
It was my dad's stroke. He had a stroke in between my college finishing and starting medical school. And up until that point, he was a cardiologist. I, at that point, thought I wanted to be a cardiologist. Probably I would have become a cardiac surgeon, in fact, but his stroke got me very comfortable with people with neurological diseases. I had an affinity with neuroanatomy. I did an extra course in neuroanatomy outside of the cadaver lab, and then it just kind of came to me. And then I just saw two neurosurgery residents in an emergency room one day, putting a ventricular catheter into a person with acute hydrocephalus. The spinal fluid comes shooting out of the head. I go, I got to do that. So that was, ultimately, we all see people we want to be like. And I think some of it was just the romantic nature of neurosurgery and the value you're bringing, the types of patients that you got exposed to, the complexity of the problem, the gratification, the challenge. I always like doing hard things. So I think it was a combination of all that.
What do you think are the biggest challenges nowadays in neurosurgery?
They've gotten more technical rather than physical. I think when I was first started, we didn't have a lot of these minimally invasive catheter-based technologies, whether it's through a vessel or through the skull. A lot of the things we do now, we couldn't have conceived of. In fact, the future of neurosurgery is almost treating the brain like a computer. Functional neurosurgery is, more or less, you make a tiny hole and then you're doing things with stimulation or ultrasound. And so that some of the beauty of the brain and the reason why I was attracted to it was the vessels of the circle of Willis, which are around the base of the brain. A lot of that is gone away. And so what you're left with is almost like a computer job. There's a lot of thought into it. It's looking at different types of diseases that we couldn't have conceived of: depression, anxiety, obesity, not to mention the degenerative diseases, Parkinson's, and things like that. So I think that the field's evolved. It's become less kind of He-Man, chest pounding, blood and guts, and more spiritual, emotional, empathetic, and finesse. And so it's evolving. I'm not sure if I would do it again given the field where the field's going, because I like the big surgeries and I like the concept of the anatomy and seeing the brain, and more is being done without seeing the brain. So, take me back. If I was 18 years old again or 22 years old again right now, what I do, I'm not sure. I have to see.
So it seems that it's becoming more robotic, more nuanced, more technologically based, as opposed to the old surgery where you had to do more things yourself. Right?
The robotics in neurosurgery isn't what it is in, say, general surgery with the abdominal or chest surgery with robotics, but robotics in neurosurgery is really trajectory planning, and it acts as a guide. So the robot guides your hand. You're still doing you're putting it in on your own. But yes, I think that it's become very technical and very driven by devices and minimally invasive, which is great for people. It's just not as beautiful and not as, I think, as dramatic. And but we're saving more lives or hurting fewer people. That's really the goal.
Do you use augmented reality or virtual reality type of technology?
We're learning how to use it, right? We haven't gotten the operating room on a consistent basis yet, but we use in the office to view three-dimensional films ahead of time. We're very close to be able to impose those images on the patient intraoperatively, but will be happening in the next 6 to 12 months, I would think.
And can you speak to the interdisciplinary collaboration, how important that is in neurosurgery, working with other specialties?
Especially at Lenox Hill it is, because we're a tertiary or quaternary system and hospital. But neurosurgery can be done in a community hospital. You can do spine, you can do very basic things well in a low tech environment. But to do it at the highest level, we really rely upon just phenomenal anesthesia, pathology, all our cancer services, our departments in ENT and other cancer fields are really important. Radiation, our imaging is incredibly important, both pre and post op imaging, intensive care unit. Our nursing, it goes without saying that if that's the swing and a miss, I think a lot of leaders should make in medicine. We focus on the guy with the big bat who can swing and hit home runs, but it's the people in the bullpen and the support that we need in order to get to win. That the nursing is probably the most critical, most underestimated value that we have here, and so we really touch on lots of different departments. As far as other surgical departments, I think we work most closely with orthopedics and spine, ENT, and oromaxillofacial plastics. We have a big program in neuroplastic surgery. So you can look around, and there's no shortage of opportunity to collaborate here or elsewhere with neurosurgery.
What about research? I know you've done a lot of research in the past, even now with the new mRNA technology and so on. And tell us a little bit about your experience and how you view research as part of neurosurgery.
Yeah, I was like an eternal optimist. And oddly enough, my first research project was in RNA biology and RNA therapy, and the woman I worked with just won the Nobel Prize. So, like, if I hadn't left Penn, who knows? But I think that's back then. I mean, I think it was a very different world we lived in. We were working for hospitals. The departments were very independent, and I think there were a lot of research opportunities, and our incentives were more pure. Today, with the bureaucracies we work in and with these large companies that we work for, especially at this level, I mean, there's a fair amount of different incentives, both negative and positive. I think so that it's easy to do other things well. Whether it's I'd say I kind of joke that the MBA is the new PhD, that there are some opportunities to be impactful in the enterprise versus in the lab, and so smart, ambitious people who want to have power and want to be impactful. In some ways, the ease of doing that through a lab research project is increasingly difficult, just because you're competing for a smaller pot of money, and also the difficulty of actually running a lab or doing really top lab research is super challenging, as opposed to being really good at outcomes or quality or technology, which is much more hands-on, and you can do that within the area of your primary work. So I do think that the impact as a researcher has diminished over time. That we still have fantastic people in neurosurgery and elsewhere doing real good research, but it's very challenging. And I think bench research and we think of as science, pipettes and things like that. That's still a great opportunity, and I wish in some ways I'd stay doing that. But once you pull out of that into more of a less academic or more bureaucratic administrative role, then your opportunities for research change. So I've really tried to influence our ability to spread it around. We have clinical trials research, we have information technology research, we have clinical research, writing about what we're doing clinically, and then a lot of our junior faculty, and then John Bookvar, who's my partner, is really a senior guy. What's called translational research, where you work with a lab and you bring that back to the bedside. I'm actually gone full circle. I'm trying to get involved back with RNA and biotech. My latest thing. I'm hopeful I can pull that off, but you never know.
That's great. Changing subjects a little bit. I love to hear more about your involvement in the with media in general, and then we can talk a little bit about social media. But the way healthcare is portrayed in the movies, for example, and how you've been able to show a more humane, way of showing doctors at the Lenox Hill, in the series at Netflix and NYC Emergency and so on. I would love to hear about how that came about, and how do you see, you think doctors are presented in the media in general? So tell us about your involvement with the Netflix.
Yeah, so on the macro level, I think that we're perceived too well and not well enough, kind of a little bit of both. I don't think there's ever been really a truly, and even Lenox Hill, for all its greatness, we still didn't go where we could have. I mean, they're because of basically patient privacy. I mean, there are obviously things that you can't show that are so emotionally difficult. You don't feel comfortable asking a patient even to consider doing that, because this is not entertainment, and there's a fine line. We had to walk that line, which I think we did a relatively good job. As far as how it happened, it was all luck. I have a talk on what's called invisible forces, where who you meet in your life and the relation you have with people really determine your career. It's like it's how you end up where you are. And I had a fellow, a neurosurgical fellow, that I just felt him to be just a fantastic person. We got along really well. He became a very close friend of mine. I taught him everything I could, even though he ended up becoming a competitor in NYU now. Which it's always the reason why people don't train you. I don't want to train you because you're going to compete with me. I mean, come on. So Erez was an Israeli fighter pilot and neurosurgeon. Came to the United States in 2013, but before he came, he was in an Israeli show called Ichilov. Ichilov is one of the big university medical centers in Tel Aviv. And this Israeli couple, the documentarians, did a show called Ichilov, and Erez is one of the protagonists in that movie, in that show, in that docuseries in Israel. It came out around 2015. Erez was already in the United States, and it was so popular in Israel that this couple decided to move to New York to do the same kind of show in America, because Israeli television market 6 million people, and to make money you got to have a bigger audience, 6 million people in Hebrew. So we didn't know it was being Netflix at the time, but they asked Erez, and Erez at that point was a young attending at Maimonides in Brooklyn, had just started there. That was his first job. And he says, "There's no way I can do this here." He's too young. He didn't have the power or the gravitas to go into his president and say, "I want to bring in TV." They would have looked at him like he was crazy. And I was a little bit crazy too, but they met with me. Erez says, "Call Langer. He might be able to help you." That's really how it happened. It's only because I had a relation with Erez that I even got involved. And when they asked me, people said, "Why'd you do it?" I said, "Well, frankly, I couldn't afford not to do it." I was like, what I knew about our environment here is that we were doing really unique things, as much more so with our minds and our hearts than with our hands. But we were as good as anybody with our hands. But I knew that the culture and the way we treat one another and the situation here, which is worth telling a story. And on top of that, how can you not do that in the competitive market of Manhattan? I mean, we already were the little startup mentality. This is 2017, 2018. We've been here a total of 5 years, and we're trying to do the NYUs and the Cornells of the world. And I didn't think we could afford not to do it, but I didn't understand the complexity of that. Like anything else, when you have a gold star idea, you have to sort of overcome. If you're worried about the risk, you're never going to go anywhere. So I took the shot and spoke to Mr. Dowling first and went down. And there were lots of issues, whether it's the unions, HIPAA issues, privacy, risk, the patient, getting patients signed up, other doctors. There's so many things. We had to get a contract, and then around that same time, they pitched it to the different streaming services, and Netflix bought the show. And that time Netflix was, this is 2018. It wasn't quite as big as it is now. And by the time the show came out, Netflix was like, Hollywood. So it really was a great experience. I mean, the fact that it came out during COVID added a whole other layer of, obviously we couldn't have planned that. In some ways, it was the best thing that ever happened to us. Particularly, not so much because we got the 9th episode out of it, which really documented the COVID experience for New York City. I think it's going to become a historic episode. But I think that it took away some of the glamour that we were sort of hoping for. I'm a very different person now than when I first started. I was excited about the exposure and being interviewed, and I enjoy being interviewed. But now it's with a little bit different purpose. Back then it was, I'm going to be famous. I'm going to get lots of patients, and I'm going to people are going to come to me because I'm on this TV show. that stuff's burned away. It's gone. And I think what we were going to be in all these red carpet things, and the health system had all these plans of, distributing this at different theaters all over the tri-state area, and it's so exciting. And then it all went away with COVID. The whole thing blew up. And I think so by taking that away, those are the things that don't matter. And what we were left with was a great show. We by that summer we had, we created this Brain Turns, which is a virtual internship for kids. We had 16,000 kids sign up from all over the world, from like 80 countries, and so the value prop there was this kind of enormous impact we have on kids and young people. And we were able to do that again the following summer, even though it was over a year after COVID started. So, the reasons for doing it originally were still there, but the secondary gain didn't really happen as much. Yet we got this huge brand and I think a lot of credibility, and it ended up being and it continues. I mean, and actually now I'm seeing patients that hear about us or heard about us. It's starting to, I see it almost every week. I call them a Netflix patient, that somebody from Indiana who's got something. There's no way we'd be seeing these people if it wasn't for that. And I'm really grateful for the opportunity. And I think it was real. That's who we are. For
That's
sure.
amazing, yeah. But that tells you what happened with COVID. There are some things you can't control. And I know in terms of your leadership style, you talk about the stoics, how you have to think about things you can control, what you cannot control, and so on. So tell me a little bit about your leadership style. How do you see that as a chairman of neurosurgery, even in other aspects like leading a Netflix show, a TV show is just probably takes a lot of leadership style, training people, dealing with patients. How do you do all of this? What's your secret sauce?
Well, one thing I'm always willing to take a risk for sure. And I'm very self-confident, but I wouldn't but my ego I think is getting smaller and smaller. It's like Albert Einstein said, ego equals 1 over knowledge. And I think that I'm still learning about leadership and still practicing. Because you try something, works, and you start to see the benefits of this. I feel more gratitude than anything. The evolution really, you're right. I mean, the transition of control. I think that there's an element of many ambitious people who want to be chairmen. That was never really a goal of mine. But yet I know there are people who were chairmen, so I had to do that. It's like they have to check a box. It's like important to them. And right there you're already on the wrong track. You may get there. In fact, in healthcare, we have a lot of people like that. And that's called a gold star leader. It's someone who's, it's part of their gold star process. They, from a very young age, especially in medicine, we're focused on our grades, and then our SAT scores, and then our MCAT score, and then our papers, and then which residency we're going to get, and then what professor this, and what committees we're on, and then what grants we have. It's an endless cycle of gold star stuff. And frankly, that 500-page CV that you hand over to the committee that's considering chairman, that's your gold star thing. And unfortunately, decisions are made based on that. I think that we still choose our leaders, healthcare or otherwise, based on variables that have absolutely zero to do with the value of yourself as a leader. And so part of that recognition, like this job, no one really recruited me for it. I came here as a director of neurosurgery. I sort of forced my way in. There were as many people who wanted me to do it as didn't want me to do it. It was very hard to move within the health system from one hospital to another because I had a big practice at North Shore. Now I'm saying, I'm going to go to Lenox. Well, Lenox has to pay me. At least they paid me. They kept me whole. But North Shore loses the volume. So North Shore is on their budget. They're like, why would we give this guy up? And why should Lenox pay for it? And, so the whole thing isn't really designed for this kind of lateral movement. So, and I wasn't recruited to be a chairman. I knew I wanted to do something substantial and special. And leadership is an acquired thing. I didn't really know what I was getting into. I think the lack of control, which you mentioned, the Stoic philosophy, one of the tenets is that you only can control what you can control. And I don't know that necessarily impacts you as a leader, but it definitely is important to understand what your true limitations are. And part of it is when bad things happen, if you can't control them, then you try not to worry about them, and you have to. And I'm not very good at that. I have a temper. I was known to have a temper. I think I treated people badly at times, not because I was a bad person, but because I always want the most out of myself. And if people aren't at my level or aren't working as hard as I am, I react. Or if they're not as, and that's really bad. One of the other things Stoics say is, Marcus Aurelius said, be hardest on yourself and easier on others. That they're just because you have this ambition, just the fact that you have this drive and want to do something, no one else cares. It's not their problem; it's yours. And the goal of leadership is to bring people up to your level and have them, see your vision. And that's a different question entirely. So that's why I'm still learning, because I'm still trying to learn what this has been such a great project. To think we came to Lenox Hill in 2013, John arrived in 2014, and we were somehow able to be, top 50 in the world in Newsweek, U.S. News, have a Netflix show, 16,000 kids on brain turns, getting 1 billion views on this and that, TikTok, social media. It's insane, and I can't tell you this is all planned. So, but the point is that ultimately the core issue is treat people kindly, be humble, and good things happen when you're talented. I think that's really the core of the whole thing.
And for such a prestigious doctor, a chairman, and so on, you might feel very self-confident doing these kind of fun TikToks and things like that. How did you get into that social media aspect of it? And it's hard to be. You do it. You and John Bookbar are so funny, and everybody loves the TikToks and so on. And at the same time, you're a very prestigious doctor and neurosurgeon and so on. How do you do that? How you can?
Well, you got to make fun of yourself a little bit sometimes. I think showing vulnerability is a very powerful tool, and I can't say that it's not normal. I think the vast majority of people in my position are not going to do stuff like that. Partly out of just they're insecure about it. They have a certain vision of how they want people to see them, and they're afraid to, do something that's a little juvenile or, sophomoric. I don't have any concerns about that. Do I worry what people think of me? Not as much as I used to, but I care if people think it's being unprofessional, inappropriate. But by the same token, in this day and age, what is that? That's the other question. It's like, if we continue to, when I was a resident, you couldn't market yourself as a doctor. People, if there was a commercial on TV or a newspaper, they'd, oh my God, can we even do? Now we have marketing budgets in our health system. When I first, you have a website, you have your own, and now everybody has websites. And so part of it is that, there's a conventional wisdom, I think, that is absolutely wrong. And one of the things about social media is that 50 and 60-year-old white guys who run departments, unfortunately, are not the best judges of what the right way to use social media is. And so I look at my kids or look at, my students and see what they're looking at. And then when you look at the way we're communicating, people don't know phone numbers anymore. No one makes phone calls. There's, even frankly, web is kind of not a great place to market yourself so much. It's expensive. No one searches the web like for that. People do, but advertising, I think, there or promoting yourself there isn't necessarily, the ROI on that isn't necessarily great. And I think print is a waste of money and waste of time. All the stuff we spend on billboards, and unless you really cream the city with purple buses like one of our competition does, I think that you have to think out of the box. And so I think that the key to social media, frankly, is understanding that it's not all the same. That there are aspects. My ex-brother-in-law runs A24, which is one of the largest movie production companies right now. They grew out of nothing. And one of their secret sauces was that they realized that each movie, they had a different voice on social. So if the movie was for 50-year-old men, they would have that voice on social. And back then, it was just primarily Facebook. Well, now there's really two problems. One is what's your voice, and two, what's the medium. So I'm not going to sound the same on LinkedIn as I do on Instagram, for example. And so we recognize that there are different audiences, and LinkedIn's probably the most professional. Facebook, the mix. Instagram, more social and more like photographic and video and really a younger audience. And obviously TikTok is what, our teenagers get their information from, and even adults. I mean, I see them all the time, people scrolling through this stuff. And I think you ignored it at your peril. I personally have pulled back a little bit, to be honest. I initially, the big, rise in my social media exposure came from the shows. And all of a sudden my number of followers went from, single digits to tens of thousands. And I think I've noticed it's just sort of, plateaued now. And I think part of it has to do with my internal change, that I found that, when you do this, you tend to see that as a measure of your success. And, if you post something and you get fewer posts, you're, whoa, I got to post things that people will like. And then
that's not very stoic.
Right. Also, all of a sudden my numbers aren't going up and you're like, oh, I'm not getting more followers. Maybe, then you're always kind of, people are DMing you, want more followers. And it gamifies this. And I decided that what I'm really trying to do is promote my team, my department, use the power of that to, expand the overall footprint of the group. And so that's a very different strategy than, one often. And so you have to understand what your strategy is. And I think that's very important.
So would you agree that I read that in the future, I don't know the percentage, whether it's 80% of communication is going to be video. People don't want to read. So video is very important to communicate in many ways. And that's something also I wanted to ask you about, because I know you've been involved in the development of an app called Playback Health that includes video to communicate with patients. In fact, we are recording this podcast on Playback Health, so let's see how it sounds. But can you tell us how that also came about? Because that applies to oncology and any type of medical intervention, and how is that being used to communicate with patients and families?
It's not easy being ahead of the curve sometimes, because even though I knew this was the right thing,
you're talking about the Playback Health,
yeah,
which is the app to communicate.
Yeah, the way it started was I was an app. I loved Apple computers. I watched my daughters doing their homework around 2006. They were now 28, so this is they were in their juniors and junior high school, and they were going to their room and they're screen sharing and they're texting back and forth and they're they're video conferencing. And it's like insane. Like, this is freeware in the consumer world, and we're in the hospitals. I can't talk to my radiologist, or I'm like, that's it, I'm doing something. So by 2008, I was able to put an Apple computer in my office, and I put one down in radiology. So I'd be screen sharing with radiology about my films. Like, if I had a film, I'd ask them to look at it with me. And that was the original idea. But then I recognized that if a patient comes in with their CD and you plug it into your computer, and I'm showing the patient the screen, why don't I record it? And then give it to the patient back. So I would go over the film with them, and I would burn a CD and give it back to the patient. Like, and would describe what I'm going to do. And it was like, rocket science, right? But, the trouble is you couldn't monetize it. It was really more or less to build a practice, do something unique, but it was so unique that no one expected it. And it was a lot of work. I mean, it took time to burn the CD and give it to the patient, so the workflow was a little clunky. But that's how it started. And the idea was to use social media or social technology or consumer technology in healthcare, and to video. I think is like you said, a very powerful medium. It's reliable. You can use what's called asynchronous communication. So if I record something, one can share with many, for education, for the patient, for the family, for the residents, for the nurses, for the anesthesiologist. And when North Shore recruited me in 2010, part of the idea was I would come here because of the size of it. Get North Shore LIJ back then, but now Northwell, to invest in it, build it inside the hospital system, and sell it back to them. That was the kind of the concept. Because unlike a drug or a device, you can't do that.
So Playback Health is exclusively used at Northwell, or can be used?
Well, now what happened was I, went through the Northwell sausage maker, and got, many failures, very difficult. The way more difficult than I ever considered. Just the bureaucracy, some of the rules of engagement. Also, back then, 2010, there was no cloud. Mobile phones were just becoming more ubiquitous. Just things like the server center data, security, who's paying for what, how you pay for it, how you securitize it, patents. I mean, it just was endless. And inevitably, around 2015, 2016, the whole thing crashed and burned. I just ran out of money. I was exhausted. But about a year later, my best friend, who now is the CEO of the company, knew what I'd been up against, had a medical experience that he broke his collarbone and his films were in place and the doctor didn't have them and this same old thing. And he got it. He wanted to run the company. So we basically externalized. We left the system internally, got the health system to invest in us on its own. And then we built Playback, and Playback's now enterprise in Northwell. We're trying to sell it all over the country. And it really has two components. One is the original piece, which is making videos, audios, documents for patients, mobile to mobile, web to mobile, or doctor to doctor. So when you see me in my office, you go home with a video of your office visit and the films. You get video discharge instructions. You get if I take a picture of your wound, or how to put a dressing on, how to breastfeed your baby, how to give yourself an injection. It's your baby, your injection, your arm.
Yeah.
So you're not looking it up on Google or something.
It's super useful. We use it in oncology too. You can have a library of what chemotherapy is,
Correct.
How to manage side effects, even how to navigate through the system. It's really helpful to have that library of content, and then you create your own, right? You see the patient. The patient takes a video of your visit with you and the films, and so it's really.
The thing I like about oncology, for example, is say you review a set of films, or there's tumor board. You can record it, and then everyone sees it. So, especially in oncology, we have so many different people as part of the care team. You have the oncologist, you have the surgeon. You may have, in breast cancer, you may have a reconstructive surgeon and a cancer surgeon, and you have the oncologist involved, and the radiation person. And once you make this, it's your voice, your impression, and it can be shared, and everybody here, they don't have to do it 3 or 4 different times, and then other people can add to it. So, it's been slow in the uptake for a variety of reasons. One has to do with who's paying for it. 2 is doctors are very set in their ways, and they don't like changing their workflows. 3 is they're not being paid to use it, and it's easy to say, oh, it's too much for me. What do I need this for? But that was the reason why I did it, and to this day, it's still bleeding edge. It's very hard living in the future. I mean, my whole practice runs on this now. Now with chat, natural language, speech, we added a whole other layer to this now this year, where anything you record, including this conversation, is turned into a note.
Wow.
So I don't have to write anything anymore. So if I'm with my patient, I'm talking to them, I just record the conversation, and I come back in my office, my note's done, and it's perfect. It's almost perfect.
That's amazing.
So
I have to learn.
This has changed my life. The thing that this does for you is it turns you into a doctor again. As much as I love making the videos for patients too, I can talk to a patient, go over their films, and I know my notes being made at the same time, and I give them a video, and I go back to my office and my work's done. So then what it does is it really uses technology for a positive purpose, not for billing, it's not for scheduling, it's not for documentation, so a lawyer sues me into something there, which is the reason why we have the EMR, basically. It's one of those 3 things.
EMR has been such a terrible thing for doctors. It's been good for the administration, management, and billing, and all of that. But for doctors, it's really, really time consuming. And so this is great to have this type of resource. I know you've dealt with your own issues in terms of healthcare. You look great, but you had an injury, right, some time ago, and you went through a lot of difficult things in the healthcare system. So what did you learn about?
I learned how great nurses are. that was really. When people say, "Oh, when you're a patient," I'm speaking at a patient experience forum in a week or two, and what they want you to hear, what they want to say, "Oh, now I know what it's like to be a patient." I was always empathetic. I mean, I built a freaking company based on being empathetic. This goes way, and this kind of whole doctor thing where you're disconnected from your patients. I mean, you shouldn't be a doctor then, frankly. And that's, I think, I definitely am empathetic, maybe more empathetic because I've been a patient. Like when a patient comes with a neck problem, hey, look at my incision. This is what it's going to look like. I mean, and I've been through what you've been through, so I can speak to that, which is kind of nice. But the biggest, most impactful thing was seeing what the nurses do for you and recognizing their unique skills, whether it's the nurse that flew me off the mountain when I broke my neck, when I was quadriplegic, to the nurse in the ICU in Denver, to the nurse who flew me, the flight nurse, when I flew from on Northwell's dime, flew me home to Lenox to have surgery here, to the nurses here in the intensive care, to my nurse at Glen Cove when I went to rehab. It's a series of nurses. And the doctors are great. My surgeons were wonderful. Dan Shubin, Mitch Levine, who are my partners, operated on me. But that fades a little. This impact that these people, and predominantly women, have on you is what you leave with. And I think that's something that cannot be underestimated by anybody. And they deserve a lot more credit than they get. And they're the little people, unfortunately, and they don't get the exposure. They don't get that's what was great about the second show, I think, is that we had nurses in there in an emergency. And I was reluctant to do a second Lenox Hill show because there was too much attention and there was a lot of sort of negative that came from that. I was really happy to see, the ambulance drivers and the nurses over at Cohen's and, other people getting credit for what they
So
do.
that's the NYC emergency series. Is there going to be a third?
I don't know. We were talking about it. I want it to be Lenox Hill Next Generation, all about our junior guys. They've been talking about maybe doing something about residency.
Maybe include other specialties.
Yeah, maybe. You never know. I hope so. I mean, that was the other thing. I had no control over that. They came to me first. They wanted me to be it. I said, let's do our whole department. Then they wanted to do obstetrics and neurosurgery because of this kind of unique nature of pregnant women and childbirth, which is so dramatic. And what you have to understand from their perspective is that what I didn't realize, I couldn't wait for them to show what's really like in the operating room. Like, oh my God, there's the brain. It's really cool. That wasn't really interesting.
They wanted to see you as a person.
Yeah.
And that's what I loved is
It had nothing to do with the and I think I'm willing to let people in. My nature is I don't mind being vulnerable, and I don't really I don't have if people think that I'm a jerk or if people think I'm sweet, it's fine. I really don't have this I have some sort of gene in me that I'm it's self-confidence, but I think what the difference that I've become, and going back to stoic stuff and through my experience of breaking my neck and having it's almost like near-death experience, is that it's incredibly humbling.
There is something fascinating about surgery. All the medical shows of surgery, but nowadays with all the advances in immunotherapy, targeted therapy, biotechnology, all these kinds of things. So I think there are a lot of excitement combining all of that in medicine, not just surgery as it was traditionally the main driver of to cure patients, but particularly in cancer, we also feel that targeted radiation, targeted chemotherapy, immunotherapy, and so on, it plays an important role. So how do you see that?
Yeah, look, there's the most amazing things are happening under our watch right now that are, cancer is a curable disease in many cases. And it's, I think that if you can imagine these checkpoint inhibitors and some of these new drugs have turned diseases that were previously just couldn't have conceived this. Now with RNA, actually, we're looking to look at a whole new group of therapies that CAR T cells, for example, which are these immunologically modified cells unique to you. Trouble is the cost of these things is like $20,000 a month. They're incredibly expensive. They take your white cells out, they genetically modify, and they give them back to you. So there's no scalability there. But now with RNA, you can actually know the gene you want, and you don't need to remove the cells. You can just basically have these targeted cells that we can give the patients as a drug. So I think that and it can affect, and it can be long lasting too. The other thing about RNA gene therapy, which was totally unknown when I was in this business, was we always thought the gene therapy to be DNA, because if you're really going to change the gene, then you've got to get some sort of incorporation of the DNA into the nucleus. But it turns out the way the immune system works is there's a thing called memory B cells. And once you expose the person to a certain gene, you create a memory cell that sits in the bone marrow and acts as and creates antibodies. So you've just basically trained the body based on some protein or some signal, and then they're fine, and you don't need DNA. And so it's so much more pure, because for DNA to work, you have to have a vector or some sort of viral. The complexity of getting a piece of gene into a nucleus is way more complicated than just getting an RNA into the cell, which is all you need to do. And so the future of RNA therapy is incredibly bright. And I think that cancer really has become, cardiovascular disease, we've gotten better for a variety of reasons, limiting smoking, we learned about statins and healthier lifestyle. And so the overall improvement in not only care but prevention of cardiovascular disease has been wonderful. And with cancer, we've gotten better. With smoking, obviously, we've really almost eliminated smoking in the kind of college-educated population. But there still remains pediatric cancers, certain blood cancers, and then these other terrible cancers that I think that this next group of treatments is likely to really significantly impact and improve the length of life of people that are just, would have died terribly even not too long ago. And that's pretty exciting. On neurosurgery, what we do with cancer, it's usually coming from somewhere else, which we're just kind of we know that when cancer goes to the brain, it's not a good thing, but our surgery is actually very effective, or radiation is very effective for dealing with metastatic disease of the brain in general. People very rarely die from cancer in the brain from elsewhere, because that's usually so bad elsewhere that the brain is sort of a secondary problem. It's like a petri dish. So if you got to be cured somewhere else, usually the brain is okay. Primary brain cancer is still an incredibly challenging thing, and there are many reasons for that. And I think, given our understanding of the blood-brain barrier, given our understanding of genetics and gene therapies, that while we're probably not going to impact those cancers as well as we might, say, prostate or breast in the next 10 years, I think the generation after that, I think we're really going to see a big impact on glioblastoma, which is the terrible disease. But that's why, if I was doing this all over again, I was never a cancer guy. I think part of it was that I didn't really love delivering bad news, and I was too much of an optimist, and I didn't want to be. I always struggle with not being optimistic but being realistic, and I don't want to sell people on something that I really wasn't true. Whereas oncology, it's kind of like being an entrepreneur. You kind of have,
you have to be optimistic.
You have to be optimistic, and you have to, even though you've got to give people hope, and got to.
Yes.
And the trouble is even maybe, but it's how you talk about it, and I think I struggle with that.
So in the neuroscience field, what do you think is the most what's going to happen in the next few years? Alzheimer's, Parkinson's, all these things there's a lot of knowledge being gathered, and still you don't see a lot of progress in the clinic. But is that an area you're optimistic about?
I think the future is, first of all, you could have this brain computer interface stuff where you're going to basically put electrodes in the brain and be able to, use your brain to interact with the outside world and control things, as well as sensors that will basically determine whether you're having a seizure and be able to treat you right away. That's going to also morph into people with spinal cord injury who can't move their arms or legs, but will be able to, communicate, interact with their brain only. That's upon us. Also, spinal cord bypass. Well, we're going to have probably devices that hook up in the brain, and you have a wire coming out of it or it's tunnel underneath, and go to your arms and legs so we can get people to walk and feel again. Sensation is as important as the motor function. That's been the challenge. You get the information coming back the other way. So spinal cord injury and this kind of reanimation of previously useless extremities, I think, is going to happen. And then the whole area of functional neurosurgery is exciting. You're going to see treatments of anxiety, obesity, depression, and a variety of these ADD. We're going to see functional opportunities here using either stimulation or focused ultrasound, which is high intensity ultrasound stimulating the brain. I think glioblastoma, we're going to see strides made in the next 10 to 20 years. Spine is going to become much less invasive, and all the vascular stuff is all going to be catheter-based. So you're you're turning neurosurgery into a catheter-based, field because
was that your main area, the vascular
yeah.
stuff?
Yeah.
And so when you say catheter-based, who does that? Is that not neurosurgeons?
Well,
Or interventional radiology?
Yeah, so open neurosurgery was the only way to treat aneurysms and AVMs, carotids, etc. Then the radiologists really pushed the envelope with catheter-based therapies in like the 70s and 80s when diagnostic angiography and then putting catheters up and putting glue or coils into AVMs and aneurysms started in the early 90s. But what's happening now is as this really took off and the technology and the material science got so much better, neurosurgeons, unlike cardiology, which really took over stenting, cardiac surgeons lost it. Neurosurgery still owns a big piece of that. The big change though now is stroke, because stroke has become the acute MI of this generation. And so all these hospitals create stroke centers, and there's a huge financial incentive for hospitals to treat stroke. And what that did is it opened up this whole field to neurology. And so there are a lot of neurologists who are doing stroke therapy. And if you can treat stroke with a catheter, they want to do some of the hemorrhagic diseases, things that are a little more sophisticated, and where there is a major reshuffle going on in this business because there's fewer and fewer people that have the experience because the same number of aneurysms and AVMs basically exist of all time. Per capita, it's not changing. And stroke was an untreated population that there's really not enough stroke doctors to treat all these people. So people are trained to treat stroke, and then the hemorrhagic diseases, things that we went into the business to treat, all the referrals are all screwed up because every hospital in the country's got a stroke center, and they're not transferring these patients. And so people with less experience are doing more and more complex things with more and more complex devices that are easier to deploy. And so the field is in a real rough and tumble stage right now as it sort of susses itself out. And I'm not sure what's going to happen.
That's interesting. As a medical oncologist, we interact with neurosurgeons in terms of metastases to the brain, and that's really important to take control of the disease. For example, patients with breast cancer who end up needing surgery and radiation and so on.
Yeah.
As you said, then we need to treat systemically to control the disease. But
one exciting thing about that, I'm going to cut you off. One exciting thing about that is we're learning how to disrupt the blood-brain barrier with ultrasound. And you HER2 breast cancer, Herceptin works great in the periphery. It's curative. But if you have HER2 in the brain, you die of brain cancer. And so what I'm more very hopeful for is this blood-brain barrier disruption will allow Herceptin as a big molecule to get through the blood-brain barrier and cure, just the way it cures breast cancer elsewhere. We believe that this blood-brain barrier disruption has opportunity for metastatic disease that could be a substantial. So the chemotherapeutic agents that work peripherally will then work on the brain, and that's really.
What about leptomeningeal disease? You have experience also injecting antibodies and things like that into the CSF.
Yeah,
right?
We haven't done that. Hopefully,
it's a little bit of a research.
Yeah. That's hopefully coming next.
But well, this has been great. Anything else you'd like to add?
No, I give you credit for doing this. I think it's important that physicians take the lead on information, and the other thing sometimes when you have non-physicians who do this, it tends to morph into more lay things, and it gets a little funny, or they ask you, hey, Dr. Langer, why is it people get dizzy when they're on that's the TikTok stuff. But I think that the doctors who recognize the power of information and can do it in a coherent, interesting, empathetic way are as valuable. It's like the same thing as Netflix. It's as valuable to the field because we want to influence young people. We want to make sure they consider being doctors, and I think this is great.
Thank you so much.